want to, since I have a little bit of time, I just want to let everyone know that over the next 4 weeks, we are going to be asking organizations to share a little bit about verbally, on the screen, not through chat, to share a little bit about your organizations, what you do, a little bit about yourselves. And so once we can figure out how many people are with what organization and this and that, we're going to figure out a schedule, and we will be asking you at different times in different weeks to be introducing yourselves. So we'll all get a chance to know everybody better. Okay, so I'm going to put my slide thing up on the screen. If I do this right. How do I get rid of this meeting is being recorded? And that thing's right in the middle of my screen.
Can you click on it says accept?
I can, oh, it just says continue, leave meeting, continue. All right, there we go. Oh, hey, this is the wrong slide. Well, the first slide is just my name, so everybody knows me. So I'm going to be talking about an introduction to Asian American and Native Hawaiian and Pacific Islander populations, and also cancer health and equities in those communities. So this is a little bit of an overview about what I'm going to be covering. I'm going to be talking about the populations of Asian Americans and Native Hawaiian and Pacific Islanders, who these two communities are and how they differ from each other. You often hear the term Asian Pacific Islander, Asian Pacific American. A lot of times it's just Asian, and people just assume that Pacific Islanders come with that. And there's a lot of differences between the two populations that often get lumped together, Asian Americans and Native Hawaiian and Pacific Islanders, as well as the many, 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 many different communities that are within both of those rubrics. So I'm going to talk about a little bit about how they differ. I'm also going to talk a little bit about the history of these communities and the relationship with the government and how that history has impacted health to this day of many of these community members. We're going to go through a few selected demographics and talk a little bit about the cancer burden, talk about cancer health disparities and inequities, and cancer incidence and mortality in the communities, and then what we can do to make things better. So I'm going to have a call to action for everybody. This is one of my favorite quotes. I think it's very important. At any time, this is important. Why is this going by itself? Okay, of all forms of inequity, injustice in healthcare is the most shocking and inhumane. And that, of course, is by the late, great Reverend Dr. Martin Luther King. So Asian American, Native Hawaiian, Pacific Islander, who are they? How do they differ? So this is the United States. This was last year, the population. AOIC is alone or in combination. So there's Asian alone or in combination. I am all Japanese, so I am an Asian alone, but my cousin, who is Japanese, Belgian, German, and English, is one of the in combination. So that's what that term means. So this is just a race and ethnicity in the United States as of last year. This is another view of it, but these, instead of being alone and in combination, these are non-Hispanic race populations alone. And then there's the Hispanic Latino, which is the dark green. So just another way of saying how big our communities are. Oops. So Asians alone, 5.9%. Native Hawaiian and Pacific Islanders, 0.2% of the total US population. And this is a slide just to show that Asian and Pacific Islander populations are the fastest growing in the United States, have been for over 35 years. Over the past 9 years since the 2010 census, the population of Native Hawaiian and Pacific Islanders alone has increased by 40%, alone and in combination or inclusive by 31.6%. For Asians, the alone population has increased by 46% in the last 9 years and 31.9% in combination. So this is in comparison. We often hear that the Latino population is the fastest growing. It certainly has a much bigger census, many more people than our communities have. But for the past 9 years, the population for Latinos has grown about 18%, which is down from its previous growth rate of 30% prior to 2010. This slide is just to show you that within the rubric of Asian and Native Hawaiian Pacific Islander, that there are many communities. These are showing just a few tiny few of the populations that are within those rubrics, and it's also showing you the difference in size of communities. This is showing the 10 states with the largest Asian and the largest Native Hawaiian Pacific Islander populations. So some of your states are in there, some of them are not. You remember that we saw that Asians were 5.9% of the US population. So in California, it's 15%, 10% in New York. So you see that in some states, it's much bigger. For the Native Hawaiian Pacific Islanders, who are 0.2% of the total US population, you see in Hawaii, a much bigger percentage of the population. And in California, they're 2.5 times their national size. Oh, I should explain that the percentage, or the percentage in the parentheses, that number signifies the percent of the population of NHPIs or Asians in that particular state. So it's not necessarily related to the number, which is the actual census count of people in those states. Since we were supposed to be in Texas right now, and many of the people are from Texas, this is just a little snapshot of the state of Texas and by race and ethnicity. Another snapshot. And this very busy slide is showing selected Asian groups in Texas and their population. This is listed alphabetically. I was thinking I should have made it by rank order in terms of number of people. But so you see that I thought that it was going to be Chinese was going to be the biggest, but it's actually not. It's Asian Indian, followed very closely by Vietnamese and then Chinese. And then this is for the Native Hawaiian and Pacific Island populations. So brief history of our communities and our relationship with the US government and how it impacts the health of our communities. So this is just a slide showing many of the communities that are within the Native Hawaiian and Pacific Islander rubric. Polynesian, Micronesian, Melanesian, think of that in the Asian community would be like East Asian, South Asian, and Southeast Asian. They're different parts of the area that we come from. And you're saying to yourself, Susan, what does that mean? Well, it's interesting that you should ask, because here's a picture of where in the Pacific these populations come from. And the little box on the right is a little bit of blow up of the place, so you can see where Micronesia, Melanesia, and Polynesia are. Hawaii and American Samoa are in the Polynesia, which is by far the largest of the groups. There's like thousands and thousands of islands with many different peoples that are in these islands that make up the Pacific. So this is the United States Associated Pacific, which means that these communities, these island nations have a formal relationship with the United States government, and there are different kind of relationships. There's flag territories, Guam and American Samoa, there's a Commonwealth and freely associated states. So the freely associated states are actually sovereign nations, and so they have ambassadors to the United States. The Commonwealth is sort of a in between the freely associated states and the flag territories. Of like the territories are similar to, I would say, like Puerto Rico. So they are American citizens and they have a representative in Congress, but that representative, much like Washington, D.C., does not have a vote, which absolutely makes no sense to me. Native Hawaiians in the United States. So you think of Hawaii and you think, oh, it's so beautiful and so peaceful. And it was a beautiful, peaceful land before the United States and other people came around. But it was a very successful, very advanced monarchy. And the United States came along and decided, oh, you know, wow, there's some great commerce out there, and we won't have to pay taxes if we own the pineapple fields. And there's all kinds of reasons why they want it. So they forcibly deposed the sovereign monarchy there and put the queen under house arrest, and then took over the government. And not too long after that, the Congress annexed Hawaii as a territory. And then in 1959, it became the 50th state of the United States. So 95 years after they deposed the queen, the United States Department of Justice declared that the United States had actually violated international laws and treaties when it annexed the Hawaii Kingdom. And in 1993, Congress apologized to the Native Hawaiian people, but they did not return the land. In the Greater Pacific, the United States interest there has been to test nuclear bombs, basically. And they've done a lot of testing, and you can imagine what that does to a land, to an ocean, and to a peoples. Many places that were bombed were places where people lived, and which they can no longer live in to this day. And they will not be able to live in for many, many hundreds of years to come. So these are just a few of the beautiful shots of testing that was done in the Pacific. And in exchange for these beautiful shots that they forced upon the people in the Pacific, the United States said that they would provide for the health, education, and welfare of the island people. So the promise was, okay, we're going to take care of you. But in reality, a lot of things happened that were not intended. Well, I don't know if they weren't intended. They were certainly not intended by the people that lived there. In addition to all of the stuff that happened to the people and not having their health, welfare, and education taken care of in the way that it should have, this rapid westernization of the people who had to leave their homes. Remember, they were living in these beautiful islands, and they're living off the land, and all of a sudden they couldn't live there anymore, and they got sent to other islands where they got put into housing that was put up by the United States government, and given rations of food, you know, Velveeta cheese and all that kind of good stuff. And all of a sudden, the cancer rates and other diseases started popping up. And many people do not know this, but the people in the Pacific have the highest cancer rates of anyone in the United States, but you don't hear about it because the population is so small. It's just a blip. And so, you know, people, you know, they say people want to get the most bang for their buck. And so they talk about the lung cancers and the breast cancers that affect larger populations, but they're not talking about the cancers that were inflicted upon the people in the Pacific. So here's Asians. We got our Far East, Southeast Asia, and Indian subcontinent. These are many different cultures and populations. And here's a map of Asia. So here's your East, your Southeast, and your Indian subcontinent here. The history with Americans, with Asian Americans in the United States has been basically a history of legally sanctioned racism and discrimination. So in the 19th century, actually even before that, the first Asians were here in the 1600s. And they actually came by way of South America. But then the businesses started saying, oh, you know, this is cheap labor. And so basically, a lot of these people were forced into servitude, and then they decided that they didn't like them. Oh God, they're so different from us. They're so different from us, and so we don't want them coming in. And then they passed, you know, so they passed laws that women couldn't come over, and so they couldn't have families, and it was all kinds of things have happened, starting with the Chinese Exclusion Act and going through the wars and all of the things that have happened. In the 21st century that we're living in now, a lot of hate crimes against Asians, also in the last century, blamed for layoff of US auto workers. People are suspected spies, they're suspected terrorists. There are many Asian immigrants that are dreamers that are totally impacted by the current administration's policies. against Dreamers. And then, of course, right now in the middle of a COVID-19 pandemic and with everything that's out there in social media, people are being blamed for causing COVID-19. And there have actually been many hate crimes and a few deaths. So Asian Americans, after the Vietnam War, history, there's always been a push or a pull coming to the United States. So can you guys hear me? I have a low system resource thing on my, I think I'm plugged in. So how do I get rid of that? So people are pulled to come to the country by dreams of making it big. It's the land of freedom. It's the land of opportunity. Or they're pushed from their countries. For example, after the Vietnam War, they were pushed because they had, many people had to leave because they had helped the Americans, and so being a refugee comes. I think being an immigrant has a lot of stressors. Being a refugee comes with a whole nother set of stressors on top of that, and which totally impact. If you just think about yourself and when you're stressed, how does that impact your own health and your daily lives? And this, of course, is true for all populations of immigrants and refugees that come to the United States. So just a few facts here. This is, I don't know if these numbers are still valid because this was back from in the early 2000s, 30 distinct Asian ethnic cultural groups, 50 distinct recognized, I would say, NHPI ethnic and cultural groups. I'm sure there are many, many more that we don't know about. In 2018, 66% of Asians in the United States are foreign born. In 2019, 24% of Native Hawaiian and Pacific Islanders were foreign born. And you think to yourself, well, what does that mean to be foreign born if you're from the Pacific? It means that you're outside of that, the U.S. Associated Pacific that has that agreement, the relationship with the U.S. government. Many dialects, many languages, and in the United States, over 100 dialects and languages are commonly spoken. So a few demographics here, so about immigrant populations. And again, this is not specific just to Asians or Native Hawaiian Pacific Islanders, but because there's such a high percentage of immigrant populations within the Asians, I'm going to talk about experience with language barriers, being socially isolated, which I think a lot of people feel right now, but it's a completely different kind of social isolation, and being socioeconomically disadvantaged. And I just wanted to remind everybody again about the percentage of foreign born. And that's going to be important as we get further on in the talk. So when we talk about language barriers, so limited English proficient is when a household, nobody in the household over the age of 5 can speak English very well or well. And usually it means that they don't speak English at all. Okay. So these are different groups within Pacific Islanders, and you can see that there's different levels, just like in everything else, there's different levels and disparities within the groups of how much the population is limited English proficient. This is for Asian Americans. You see there's some populations, so the bar with the 50 on it, that's Vietnamese. This is in 2009, so it's this data is a little bit outdated, but I couldn't find another source that had this many Asian populations altogether, so I used this old slide. But it just, again, shows you the difference. How do I get rid of this thing? Sorry, I'm just seeing all kinds of stuff blocking my screen, so I'm trying to get rid of them, and I don't know how to do it because I am totally technically inept. My apologies. And now my slide is not moving forward. Okay, here we go. So I was born in the United States. I think I'm fairly well versed within the medical system. I am a 29-year cancer survivor. I have had 3 cancers, and I've dealt a lot with the medical system. And it still confuses me. Imagine if you don't speak English, or you don't speak English very well, how do you communicate with your doctor? I often had trouble communicating with my providers. And you know, how do you know what that prescription on your the label on your prescription medication bottle, how do you know what that means? And how are you supposed to take this medication? And on top of it, if you can't afford to buy all the medication that you need, how do you figure out how you're going to ration that medication? There's a lot of problems with it. And what ends up happening is that young children often end up being the interpreters for their parents or their grandparents, which totally interrupts the fabric of how the hierarchy in many families is supposed to work. So there's bipolar distribution of the demographics in different Asian American communities. When we look at this myth of the model minority, the model health minority, where Asians, so these are the Asians that were here longer. So, you know, they're so good and so quiet and so subservient, and you know, they're not making any noise or mess. I think this was really developed as a way to ostracize communities, African American communities that were protesting, rightfully so, back in the 60s. And the Asians are just, you know, being quiet. And you know, I think that really was more of a tool that people were using to pit communities against each other. On the other side, then, the newer immigrants, and this is after the end of the Vietnam War, not doing as well. So they are not as healthy. They're not as compliant with their health things. And I can't read what this says because I can't get rid of this thing. Anyway, it's supposed to say, it doesn't matter what kind of stereotype it is, whether it's a good stereotype or a bad stereotype. Ultimately, in the end, they all result in adverse outcomes. This is just an example that I found of this bipolar distribution. This is for household income in 2015. I was actually surprised that Japanese were closer to the middle than the right side. And if I could, which I can't, if I could move that, so behind the people that are on my screen here that I can see, I believe they're, oh, now I don't remember because I was going to say it's Filipino. I can look it up real quick. But this is just an example of this bipolar distribution. Oh, it's not. It's just the Asian Indian, their income goes way up. Here's poverty rate. So this is the United States. This is looking from the 2007 to 2011. And this is by race and ethnicity. Does anyone know how I get rid of this? Somebody's is in the waiting room and is trying to enter the meeting. Can somebody admit this person if they're supposed to be in here so I can get rid of it? Thank you so much. So these are just the poverty rates for the United States broken down by race and ethnicity. But, well, and let me show you, so this green, sorry, I'm pointing at my screen like you can see it. This little green line here, 17.6%, that's Native Hawaiian and Pacific Islanders alone. This light pink here, 11.7% for Asian alone. So that's low in terms of poverty rates, when the national average here is 14.3. But if you disaggregate the populations, this is what you find. So here we have those populations by race and ethnicity. Here's the Asian alone poverty rates. And then everything to the right side here are different communities. And you can see that there's a really big disparity in terms of the poverty rates. It's even more stark when you look at Native Hawaiian and Pacific Islanders. So here's the Native Hawaiian and Pacific Islander poverty rate. But look at this huge gap here. And this is not that long ago. So why does this matter? And it's time for a break. How are we doing on time, Dave? Oh, let's see, I gotta share again.
Susan, do we need to take a picture again first?
Oh, should we do that?
Okay.
Not everybody's back from their break.
Okay.
Yeah, there's a lot more blank screens now than there were earlier. So I can only see. We'll wait to
Okay.
take a picture for when more people are back.
Okay, no
Back
problem.
to this. Okay, so to continue, I was talking about demographics and bipolar distribution and disaggregating data. And why does all this matter? Because when it comes to cancer, Asian American and Native Hawaiian Pacific Islander communities have cause for concern, as well as do other communities. So when you compare Asian American, Native Hawaiian, Pacific Islanders with other US populations, the cancer burden is a little bit different in our communities. It's unique, it's unusual, and a lot of it is unnecessary. So part of the uniqueness is that there are lots and lots of different cancers, and many of them in the United States are low incident cancers, but it is very common among Asian American and Native Hawaiian Pacific Islander populations to have these cancers that are otherwise low incidence for the general population in the United States. So, for example, stomach cancer, liver cancer, thyroid cancer, very high rates in many of these communities. So now you'll see the term here, API, Asian Pacific Islander. When that is up there, it's because the data or the source that I got this from, this is how they reported their data out. And it's all aggregate populations, all the Asian, Native Hawaiian, Pacific Islander populations lumped together. And I'm going to talk a little bit more about why that's a really bad thing. But when the information comes that way, I have to report it that way. So for a long time, the American Cancer Society, the National Cancer Institute, the CDC, NASAR, which is North American something Cancer Registries, a lot of different organizations every year put out an annual report to the nation on the status of cancer in the United States. And they focus on a lot of times they focus on different topics in addition to just putting out the data that's known about cancer in the United States. So over time, Asian Pacific Islander women were the only population group, and I'm talking population for men, so they're different from API men as well as from other race categories. No decrease in cancer incidence and an overall increase in cancer mortalities. And so this information is from 1990 to 2000. But that trend has actually continued. It's only been in the last 5 years where the rates or the trends have flattened. We talk a lot about COVID-19, how you want to flatten the curve. You got the mountain, and the other side of the mountain, you want to flatten the curve. So over the last 5 years, the cancer rates for API women in aggregate has started to flatten. Something that I've always found to be really interesting. So in the United States, heart disease still is the overall leading cause of death across all racial groups, across all men and women. But in Asian American, Native Hawaiian, and Pacific Islander females, cancer has been the #1 killer since 1986. In 2004, cancer became the #1 killer of Asian American and Native Hawaiian Pacific Islander men. And I can say AA and NHPI because that's how the report it separates Asians and Native Hawaiian Pacific Islanders. Since 2004, American Indian Alaska Native women now have cancer as their #1 killer, and Latinas, female Hispanic Latinas have cancer as their #1 killer. All other groups still have heart disease as their #1 killer. I just find that to be fascinating, especially since cancer has been the #1 killer for Asian American, Native Hawaiian, Pacific Islander women since 1986. And I went back and I looked at every year, that information comes out in a report called Health US, and it comes out annually. It's put out by the CDC, and they tell you what the top 10 killers, and you can see differences by age. I keep getting this low system resource, but I'm plugged in and I think I'm good to go. So that's where I got that data. I just went back and I looked at every report that I could get my hand on, and in 1986 is when you saw cancer for the first time being the #1 killer of Asian American Native Hawaiian. Back then, they were listed as API women. It's been disaggregated since then, but I've just always found it to be interesting. Unusual. So the high incident cancers in Asian American, Native Hawaiian, Pacific Islander communities are both chronic and they're contagious. So chronic is a disease that you get, as long as it's treated early, you can live with it for a long time. And for immigrant populations, acculturation and time since immigration in the United States can either be a healthy factor or an unhealthy factor. I used to say, when I talked about breast cancer in Asian immigrant women, I used to say that their #1 risk factor for breast cancer is moving to the United States, because so my first breast cancer was in 1991. I was 34 years old, so I've been doing this a long time. And back then, the women that were getting breast cancer in the United States, the immigrant Asian women that were getting breast cancer in the United States were getting it at younger ages. And they came from countries with at that time, lowest breast cancer rates in the world. Things have changed since then, but for them, coming to the United States meant that they had a higher risk for breast cancer. And a lot of factors that go into that. On the other side, a lot of Asian countries have very, very high rates of stomach cancer, which is why you see such high rates in the United States among Asian and Pacific Islanders. But when they come to the United States, those rates actually go down, because the rates in the country where people came from, their country origin, were so much higher, and they're so much lower in the United States. And again, there has a lot of this has to do with lifestyle, diet. But I just thought that was an interesting thing. And then contagious. So we're talking about viruses. So not in the realm of COVID-19 virus, but in the realm of HPV, the human papilloma virus, and the hepatitis B and hepatitis C viruses. Left untreated, these viruses and illnesses can and do turn into cancers that can be life-threatening. So the HPV, untreated, can turn into cervical cancer. Hepatitis can turn into liver cancer. And these are, so the sad thing is the cervical cancer, no women in the United States should die of cervical cancer, because you know, if you get your pap test every year and it gets anything that shows up, they treat it right away. These things, cancers shouldn't develop, and nobody should die of a cervical cancer unless it's a very rare case. Unfortunately, for many immigrant Asian women and for Pacific Islander women, high rates of cervical cancer, but they don't get the treatment. They probably, they may not have insurance. They don't have access to the medical care they need. They don't have access to the timely medical care they need. In the Pacific, you can be diagnosed, you can take a pap test and see that you have a problem that in the United States would get taken care of right away. It would be done in your doctor's office that day, and everything would be fine. In many of the Pacific Islands, there's nobody there to treat that. So you have to then be able to travel to Hawaii or on the mainland in order to get this taken care of. And so it's a big difference. You want to talk about the disparity there. But these are cancers that actually start from viruses that are contagious, that people catch from somebody else. And unnecessary. So I was just talking about unnecessary deaths from cervical cancer, unnecessary deaths from liver cancer. A lot of this has to do, as I was talking about, lack of healthcare access, but also lack of awareness, lack of an understanding and trust in the US healthcare system. For those of us that grew up in the United States and have dealt with the healthcare system all of our lives, it's complicated enough. But imagine if you come from a country where the healthcare system is completely different, where it's just completely different, or it's non-existent. And that creates a lot of barriers. And we were talking earlier about stressors for immigrants and for refugees, and you add all that, you pile that all up, and it just ends up in these unnecessary illnesses and unnecessary deaths. I'm not blaming the person, it's the situation. It's a sad thing. And we have seen over time, I think the first study Margie Kagawa-Singer put out, I think it was in 2007, 2009, where she looked at cancer screening rates among Asian American, Native Hawaiian, Pacific Islander women in California. And they were so far lower than the rest of the state and much lower than the national average. And I was just reading, in preparation for this talk, I was reading a more current study, which came from 2019. And the screening rates for Asian American, Native Hawaiian, Pacific Islander women in California are actually lower now than they were before. It's very sad. But those lower screening rates are going to cause unnecessary cancers and unnecessary cancer deaths. And then, of course, there's big tobacco. Always looking for a new customer. They flood Asian and Pacific Island nations with free tobacco products, all kinds of incentive things. They give you, clothes and posters and all kinds of stuff because they want people to smoke their product. And then you smoke their product and you become hooked, and you become a customer for a long time. And then there's also, and then a lot of the people that get hooked on smoking at some time may immigrate to the United States, to the mainland. Then there's also a lot of targeted marketing for tobacco products in US communities of color. I want to say maybe 15 years ago, maybe longer than that, there was a big study here in San Diego County where they looked at the number of posters, the number of advertisements in communities of color that were focused on tobacco. So not only the number, but also how densely packed they were in different communities. And they found among Asian communities and Native Hawaiian and Pacific Islander communities, especially in their grocery stores, they were just packed everywhere. Posters just lined the windows, they lined the counters, and it was all about smoking. And so the big tobacco really knows, they target so well, and they put in their ads someone that looks like the community that they're trying to get hooked on this. And so along with the popularity of e-cigarettes and hookah lounges, which by the way, a hookah, if you go to a hookah lounge, you're getting 36 times the amount of smoke and nicotine in your body than you would by smoking a cigarette. But these things are very popular right now, and especially among youth and teens. And it's adding to an already high tobacco use prevalence in Native Hawaiian and Pacific Islander communities. Over time, typically Asian communities have had, as well as African American communities, have had pretty low rates of smoking. But we're seeing in both of those communities, smoking rates are starting to climb. I'm on week 4, I think is it 4 or 3? We're going to have somebody talking about tobacco in these communities. It's going to be a great talk, and I really encourage everyone to listen to that. And they'll be able to tell you what's going on and why these rates are climbing. and how they're trying to address that, how they're trying to fight against that. Okay, so what is a cancer health disparity? It's pretty much what it sounds like. It's the disproportionately greater burden of disease in some communities than in other communities. I do want to say that regardless of your racial and ethnic group, if you are poor, and that includes if you are a poor white, many rural populations are very poor, you're going to have a greater cancer morbidity and mortality than your higher socioeconomic status white Americans, which obviously makes sense. But interestingly, if you are someone that, if you are an Asian American woman that's educated, has health care, goes to the doctor on a regular basis, you may still have higher rates than your white counterparts. And that's a question for why is that? Health inequalities, there are measurable differences in health status and outcomes. It's more of a relational term, so when inequalities exist, you know that some people have more than others. But I like the terminology health equity. Health equity is the absence of systemic, that's important, the systemic disparities in health between the different groups. So if health equity is the absence of these systemic disparities, then health inequities are the presence of these differences. And how can somebody get rid of this? Julia's in the waiting room. So equity suggests a value judgment. So equity, you think of equity as something that's fair and just. You think of something you think of inequity as something that's unfair and unjust. And this is, I'm sure a lot of people have seen this picture before, this cartoon before. This is a picture showing disparity. So there's 3 kids who they want to watch this baseball game, but they're just, the disparity is in terms of their height. And so to all of them can watch the game, the equal thing to do is to get them all the same size box. But that doesn't mean that they can all see the game. The equitable thing to do is to make it so that everybody has the same outcome. Everybody, you arrange it. It may not be that you give the resources to the communities that need it the most so that everybody has the same outcome. And I like to think of equity as in tune with social justice. That's a big thing for me. So here's cancer incidence rates. This is the United States. This again is by race and ethnicity. The important thing to see here, again, we have Asian Pacific Islanders all aggregated together. Blue is men, the mint green is women. The important thing to see here is that the rates are lowest across all the different racial and ethnic groups. This is for incidence of cancer. This is for mortality of cancer. Same thing, the rates are lowest in this aggregate Asian and Pacific Islander population. This is looking at breast cancer, just breast cancer. And again, we are not the lowest. Asian Pacific Islander women do not have the lowest breast cancer incidence of breast cancer, but we have very close to being the lowest. And again, this is in the aggregate population of Asian Pacific Islander women. Now, if you disaggregate that number, so on the far left is non-Hispanic whites who have always had the highest incidence rates for breast cancer, followed by non-Hispanic Black and African American women who have always had the second highest rates. Oftentimes it's closer to the white rate. And then falling to the right of that is the non-Hispanic API, aggregate API. If you disaggregate these communities now, going to the right, in the mint green are the Native Hawaiian Pacific Islander populations, and the light pink are the Asian populations, and you see the big disparity in terms of the rates of cancer. Some are much lower than the API rate, and some are much higher. And you see for Native Hawaiian women, they have much higher rates of breast cancer than non-Hispanic whites and Blacks and African Americans, whom we often think have the highest rates. The problem is that Native Hawaiians are the largest proportion of Native Hawaiian and Pacific Islanders. But Native Hawaiian Pacific Islanders are only 7% of the API aggregate population. So if things are reported as API, as they often are in cancer and other health reports, that gets totally lost. What also gets lost is that, for example, Vietnamese and Korean women have very low rates of cancer. So their rates actually get inflated. Native Hawaiian rates, Samoan breast cancer rates, they get completely lost. You don't see those at all. This is a very busy slide, but there's two things to look at. The black line, kind of lumpy line at the very top, this is over time from 1988 to 2012. This is the incidence of breast cancer over those years. And it's a little bit lumpy, that black line, but you see that on the right side at 2012, it is slightly lower than when it started out in 1988. The thing to take away, all these other lines, all these other colors represent Asian populations in the United States. The thing to notice is that they're all trending up. Even the green line here that looks kind of like a mountain here. So it was going up and then it started coming down, but it's still higher here than where they started. All of these populations, breast cancer is higher over time. So given these data, why are, in quotes, API women most often reported to have the lowest breast cancer incidence and mortality rates in the United States? And just asking, could that aggregate API cancer data provide a clue as to why some medical providers tell their Asian and Native Hawaiian Pacific Islander female patients who, like I did, present to their doctor with a suspicious breast lump and they're told, oh, don't worry, you're too young to have breast cancer. You have no family history of cancer. And besides, Asian women don't get breast cancer. That was 29 years ago that I was told that. I do a lot of speaking around the country. For 20 years, I always had somebody come up to me, at least one person come up to me and tell me that they heard the same thing, or their cousin heard the same thing, or their aunt heard the same thing. I haven't been speaking as much over the past 10 years, but I wonder how much that's changed, because the cancer rates are still listed in aggregate API. So these are some of the factors that contribute to cancer health disparities. For Asians, very heterogeneous populations. Again, 66% foreign-born, and Asians comprise 93% of all U.S. population. So these things here are just facts. They're not necessarily the reason that contribute to the cancer health disparities, but I'm gonna kind of bring it back to that in a little while. Native Hawaiian Pacific Islanders, also very, very heterogeneous population, 24% foreign-born in 2019, and they comprise, as I said earlier, only 7% of all API populations. So what does this mean? So for Asians, US-born Asian women with breast cancer are hidden within the larger share of foreign-born Asian populations, and these are the women that originally immigrated from countries with the lowest breast cancer rates in the world. Asian immigrants are often much lower than the national average, and we know that cancer is a disease that normally happens. The older you get, the higher your risk of cancer is. So American-born Asian women, because the percentage within that group of Asians is so much smaller, even though they have higher rates, that gets obscured by this, again, aggregate, even though it's listed as Asian, it gets obscured. Native Hawaiian Pacific Islanders are all but eclipsed. Their rates are all but eclipsed behind the Asian populations, who comprise 97% of the aggregate API population where these reports are given. So extending the practice of reporting low aggregate API breast cancer data will continue to obscure significantly higher as well as significantly lower breast cancer incidence and mortality rates among some Asian or Native Hawaiian Pacific Islander communities. So further research, grant funding, and health policy decisions are predicated on these data, which are accurate, but very misleading, which means, again, when you talk about, as I did earlier, you talk about the model, the myth of the model health minority, when the data, which is accurate in the aggregate, shows that there is a very low incidence of breast cancer, both incidence of mortality in Asian Pacific Islander populations. The resources don't go there. The resources for research, resources for treatment, resources for interventions don't go to where they actually are needed the most. This is a big thing. This I put in because every year in San Diego, there's a Pacific Islander Festival. And this one year that I was there, and I was working at a health booth, I saw this young woman here, this young girl, and I asked her if I could take a picture of her. And she said yes. I asked her mom, and she said yes. So this t-shirt says, "Sorry, don't speak Spanish. I am Hawaiian." And misclassification is also a big problem. So it depends on where you are located, when you get sick, when you are born, when you die. Different states and different counties handle things in different ways. In some states, when you die, your race is put down by the coroner. It's not necessarily put down by listed by a family member, or they're going through their records. So misclassification is a big deal, because when you're talking about rates again, how accurate are rates? Even if they are disaggregated. And this slide is based off of a study from 2009. It was looking at the next, I guess that would have been the next 20 years. So they were looking at cancer rates in 2009, 2009, and then they're extrapolating ahead based on demographics and the trends of cancer, rates, and they were looking to see in 2030, what are cancer rates going to be? So they saw across all groups that the cancer rates were going to be rising. So if you are a person under the age of 65, your cancer rate in 2030 is going to be 11% higher than it is in 2020. If you're over the age of 65, your cancer rate's 67% higher in 2030 than in 2020. And you can see here, they have non-Hispanic whites and minorities listed. But fortunately, they do disaggregate those minorities. So for African Americans and Blacks, in 2030, their cancer rates are going to be 64% higher than in 2020. We're talking a 10-year period. For American Indian and Alaska Native, we have very high cancer rates. Again, a very small population. Their 2030 cancer rates are going to be 76% higher. Multiracial, which is anybody that's more than one race, 101%. For Asian Pacific Islanders, again, in the aggregate, but it is in the aggregate, so that 132% really makes you wonder. It's probably a lot higher than that in some communities. And Hispanics, again, this is in the aggregate. So across different Latino populations, I'm sure that 142% is probably low. So it's a little scary about what we're headed towards. So what can be done? Number one thing, we gotta disaggregate the data. So not just, we got to get rid of this API. We have to disaggregate the Asians from the Native Hawaiian Pacific Islanders for all the reasons that we talked about earlier. And then beyond that, within Asian groups, within the Asian rubric, we have to disaggregate the different groups. Now it gets a little bit difficult when you're talking about cancer rates, because you have to have a certain number of people to make sure that the rates are, what's that term I'm looking for, Virgin? Well, you guys know what I'm talking about. I mean, because if you have too low of a number, if your N is too small, then you can't rely on the data that comes out. Again, we have to disaggregate Native Hawaiian and Pacific Islanders. from each other, because the health outcomes, the experiences, what people have access to are very different in the different United States associated Pacific areas, very different across the different island nations. Also need to disaggregate by age, generation in the United States, what country people were born in, how long they've been here, what year they entered and how long they've been here. When you're talking about disease, underneath this thing that I can't see, is talking about your age at diagnosis, your stage at diagnosis. A lot of these things really make a difference in terms of what you're looking at. So here's a call to action. We need to promote community engagement. Community engagement. Community advocacy trainings. All of you are here doing this community advocacy training, which is awesome. These are the kind of things that allow our communities to become educated about ourselves, about each other, other communities, which I think is really important, especially now, but always important. For many years, I was involved in an organization called the Intercultural Cancer Council, and I first joined it in 1995. It was a national organization that was, as the name implies, intercultural, it was multicultural. There were differences not only across all racial ethnic groups, also included rural whites and poor whites. It included people that were immigrants, all different, refugees, all different languages, spoke all different languages from all across the country and in the Pacific. And in Puerto Rico and the Virgin Islands, it was a very diverse group, and we were all focused on one thing: cancer in the underserved communities of color and poverty and disparities. And we would say that when you come to the door, when you come to a meeting, you leave your personal interest, your hat, you leave it at the door. And when you come into the meetings, what we're doing is we're talking about everybody. And we're talking about the things that are common across all the communities, but also if one community has an issue that really needs to be focused on, then we're all there focusing on that issue for that community. Community-based participatory research, also a big thing. I used to chair a CBPR training. It was a training program, so we had two sessions every year. We had 2 meetings every year, and we brought in people from the communities, and we brought in researchers from academics and from industry, and we paired them up so that they could do research together. Community-based participatory research means that the community members are part of the entire research experience from the beginning. So the community decides what is the research question. They are involved in recruiting the participants. They are involved in setting the question, in evaluating the data. They are listed as a co-author on any publications that come out. And most importantly, the community is the keeper of the funds. So the grant goes to, and this doesn't always happen, but when it works right, the grant funding goes to the community, which has power, which gives them automatically power over the researchers. So you want to bring in that equity. What we have is that you have experts. You have your academic experts that are experts in research and whatever the particular field is, in epidemiology or cancer, diabetes. But you also have community experts, because people in the community are experts in their their shared lives and their lived experiences. And that's very important to bring to this, because a good friend of mine in the Intercultural Cancer Council, and I don't know if we're going to be able to see this, he always used to say, if the problem is in the community, then the solution is in the community. And he's right. He's absolutely right. So here's your call to action. Asian American, Native Hawaiian, Pacific Islander cancer survivors and advocates, and those in other communities of color, poverty, and oppression must play a key role in local, state, and national efforts, whether that's research, programs, interventions, health policy, to eliminate cancer health disparities and promote health equity in the United States. It's the only way we're going to achieve equity in healthcare and health outcomes for cancer and other health issues that are scourging all of our communities. And this is part of the call to action. Again, you're all participating in this community professional education, awareness, advocacy trainings on cancer in our communities. This means including healthcare providers, biomedical and social researchers, programmatic and research funders, the people that have the money that allow everyone to do what they need to do, legislators, health policy, public. And a very important thing, and this is what we practice in the Intercultural Cancer Council, and this is at the core of my being. We need to cultivate community partners and cross-cultural community allies to collaborate on issues of mutual interest and benefit. We need to develop and nurture these partnerships built on our personal relationships so that we can gain mutual trust and be strong and supportive allies on issues not only of importance to all of us as a collective body, but as I said earlier, if there is an issue, for example, right now, Black Lives Matter, in terms of what's going on with the unnecessary and I don't even have a word for it, all the killings that are happening in the African American community. We have to be partners because they need us now. It's like, I liken it to NATO. So NATO, the different nations in NATO have an agreement that if one country is attacked, then all of those countries within the NATO partnership considers themselves to be attacked, and they all join forces to go against who's attacking them. That's what I think we need to do in our communities. If one community is attacked, then we all need to join forces with that community, because in the end, it brings better equity, it brings better social justice. We all need to have that, and makes everybody's lives better. And what you can't see, I don't know if you guys can see it, but what I can't see in my screen, it says to practice cultural humility. So cultural humility is beyond cultural sensitivity, it's beyond cultural competence. It's when you're trying to learn from another community. So you're being a sponge, you're absorbing all the information that you can, but at the same time, you're learning as much as you can about the background, the history of that individual or of that community, of what brought them to where they are right now. And you're looking at yourself and you're acknowledging that you have biases, and you're trying to evaluate your own biases and bring that into the fray. So it's cultural humility, because no, you're saying, you are agreeing that you need to learn from others, but you also need to understand that you come with your own biases. And so you have to include that in the whole picture. Another one of my favorite quotes: knowing is not enough, we must apply. Willing is not enough, we must do. And that's my presentation. I apologize for talking so fast, but I think we have some time. So if there are questions, we can take them.
Oh, yes. I'm sorry, Susan.
It's just a comment based off of what you were just saying. If I have said anything that anyone knows was wrong, or I interpreted it the wrong way, or if you have new information or you have other information that you want to share, please do. Please do. I am not an expert in all of this. I do this just because it's important to me, but I'm not the expert in this. Like I said, the community people are the expert. You guys are all part of my community. And so I welcome your input. I want to make my presentations better and stronger, and I want to make sure they're right. So I welcome your input.
And thank you for modeling one of your very last slides about humility. So that's modeling the humbleness of where the expertise lies. The expertise lies in the community, and the community that's impacted. So I'm going to quickly scroll through the chat to see if there were any comments or questions. And I encourage you to think, if you have any comments or questions or clarifications, please feel free to share them. Minister Dr. Ora Hotep, whenever you look at non-Western Europeans' relationship with the US, it's always about oppression. There's some comments about snack boxes and virtual backgrounds, which I will skip for now. Let's see. One question here. I'm wondering if this aggregate data is available by region. Do any of groups have data on DFW specifically, which I'm assuming is Dallas Fort Worth? So I don't know if there's any comments or responses to that inquiry.
So maybe the folks in the DFW area know, have more information. Not every state is required by law, like California is, to provide detailed disaggregated data for a lot of stuff, but including cancer and health. I think Hawaii is. More states are starting to, but a lot of states still list for their race data, white, Black, Hispanic, and other. So it's not easy to get the data in every state. There are some counties that do better than their states. And you know, sometimes the National Cancer Institute will put out a report that has detailed racial and ethnic information. Very, you know, they take out, they look at it in terms of granular communities. But when I have data that's old, it's because that's when I found some really good information, but I haven't found studies since then that break it out in as much data as I want it. So, but I know that Texas is supposed to be one of the states that does disaggregate data, but they do, I think they do list Asians and Native Hawaiian Pacific Islanders separately in a lot of cases.
Yeah, can I add something?
Yeah, you should know.
Yeah, okay. The Texas data, okay, if you talk about cancer, the website, Texas Cancer Registry, okay, they have it, but they put all the Asian American Pacific Islander into one group, okay?
I do.
But at least you are able to access that data as an Asian and the Pacific Islander as one group by county, okay, just online, it's a public record. But if you want the specific disaggregated data by different Asian subgroup, you can ask them, send an email, and they will send to you. Okay, Chinese, Vietnamese, they will send to you. Before several years ago, there was one Dr. David, I forgot his last name. He was very responsive. If you send to them, they will give you within a couple of days. But lately, I think he retired, and then they have another person. It was so difficult to get the data from that person. It takes almost a week or 2 weeks. But they will send you. So that means they have the data. Texas has the data, can be desegregated by different Asian group, but you have to request. Okay, but the whole group, yes, they have. In terms of demographic information, I think census is the best place to find for the DFW. Okay. Dallas and Fort Worth area. But lately I found out the census retire, what they call, community fact fighter.
Yeah. It used to be so easy to find stuff, and now you go there and they refer you back to census.gov.
Right.
Which is not helpful at all.
I just found out, I think they retire in July, right? And now it's too much. It's just like a brain jungle. There's no way you can find. I was so frustrated because before, when I write some grant, I can easily go to the fact fighters. Okay, I think fact finder, right?
Yeah.
It's so easy. You can do it by city, by metropolitan area, by county, by different Asian group. And now I can tell you, so far I have no luck. I was so frustrated. I don't know, this is a part of the administration trying to hide the data, or I don't know. It just totally. It's so difficult to find the data.
Very frustrating. Yeah.
Yeah, very frustrating. Yes.
Okay.
But at least the cancer data, I know you can talk to the go to the Texas Cancer Registry. Okay, it's a public record. At least now they have a group. They didn't have it several years ago. I think that recently they start to put the Asian Pacific Island in one category. So you should be able to get the data by different cancers, prevention, incidence rate, and also mortality rate by county. Yeah.
So here's the call to action for the folks in Texas. They have the data. They could report the data.
I talked to the I talked to our representative.
So the communities need to advocate. You guys need to go and you need to demand that that data be reported and put on the internet. Make it accessible to everybody. You shouldn't have to write to someone and wait for 2 or 3 weeks to get it. If they have that data, they can report it.
Well, I try at that point, but at least we got the aggregated one, okay? Because it was not. First, when I started to involve the community 10 years ago, it was under others. It was totally put in other group. This several years ago, they started to put us one group. So we were able to get us a group, but not disaggregated by Asian group. Yeah.
So maybe at a later time, we could figure out a way to share the different contact points where data may be accessible for Jen, as you're saying, so people know. And then Susan, I believe the issue you're addressing, maybe throughout the calls, there could be ongoing conversation about what are some potential next steps for people to come together to advocate for data information needs. Okay, I'm going back to the chat. Another question was there any suggestion or hypothesis on why the screening rates had dropped in California?
The article that I read just said that the screening rates had dropped, but more study needed to be done, which is always the standard line. More study needs to be done. So hopefully somebody is going to be doing that study to find out. But yeah, I was shocked. I was really shocked.
Okay. Okay. All right. Thank you. Any other questions or comments or clarifications, reflections on the information that Susan had just presented? And I do want to recognize that was a lot of information in a short period of time, and I'm still processing, and that was a lot of data.
Or if you have any data or anecdotal stories that can help to, bring to light more of the data, bring the data to light, that would be great too. Anyone wants to share? I know all of you guys have this stuff. You guys have that information.
Well, perhaps another way to approach this would be, and feel free to use the chat function if you like, or we can share, or you can share with the group verbally. Is I just wanted to ask, was there anything that surprised you? That perhaps you, hearing Susan's presentation, that you were not aware of, be it particular cancer rates, be it particular the historical perspective that perhaps has led to the conditions, the built environment and social determinants that have led to different kinds of rates. Just overall, was there anything that surprised you, perhaps that you learned? As well as were there some things that Susan shared that just were confirmed for you? It's like, I knew that, or now that I have that data confirmation, I have a better idea or approach on how to address this issue, or I had a feeling about that, but I wasn't, quite sure, but now I know it. So I'm just curious if there's anything that you would want to use in the chat, or just raise your hand or use a reaction so I can acknowledge you can share, because what I wanted just to briefly share, and I've heard Susan present before, and just in my cultural humility, I think I'm more familiar with the issues that are East Asian, Japanese, Chinese, Korean, less familiar with other Asian groups, South Asia or Southeast Asia, and still learning about the huge differences between Native Hawaiians and Pacific Islanders, even though politically we are grouped together as one category, a group of people. That I'm making an overstatement. I know we all realize there's diversity in diversity. I'm just saying I didn't realize how much I did not know.
Can I add to that, Dave?
Mm-hmm.
So I am a Pacific Islander, and Asian. My mother was from the Philippines and my father is from Guam. Susan, I really like that you included the Compact of Free Association States and island nations, because what a lot of people don't understand is the United States made a promise to these island nations and they did not follow through. So right now, people from the Marshall Islands are one of the highest fatalities of COVID-19. They pay taxes, they can travel throughout the United States, but they don't have access to health care through Medicaid through Medicaid or even food stamps or any kind of social services because of the promise that was supposed to happen, yet they didn't fund it. So a lot of these different organizations or different states have created a fund specifically for that community. We have a growing community here in Arizona. They tend to also go to Hawaii, Guam, because they have access. They are allowed to get medical care there, but that doesn't mean that they get the care. They experience segregation, or they experience racism within our own Pacific Island communities. So, and a lot of people don't realize that. And they're the ones that are being hurt the most because they work in meat packing facilities. They work on chicken farms. A lot of them are recruited to these chicken farms, and that's where they work, and they've been getting sick and they're dying. So I really appreciate the historical background that you provided, because a lot of people don't realize that they themselves, the people that we promised, their islands were bombed, their islands were used as testing grounds, are still suffering many years later. So
and
thank
we'll
you for
continue to suffer for hundreds of years into the future.
Yeah.
Thank you, Lisa. Any other confirmations or surprises anyone wants to share? I'm going to go to the chat from Shannon. I was not familiar with any of this, so it's very informative with so much insight. My focus has primarily been on African American and Latinx community, so I really appreciated it so much. So thank you, Shannon. I think we're all learning. But anything else anyone wants to share?
I think, Shannon, if you feel comfortable doing so, I would love for you to share some of the experiences and some of the insights that you have from your work with those communities. And anybody else that's on the call that works with other communities, we can all learn from each other. I think it's really important that we do that. And just like within the rubric of Asian, there are many different communities and cultures. We know that's true for Black communities. We know that's true for the Latin communities. We know that's true for American Indian communities. We know that's true across the board. And the more we can learn about it, I think would be great. All this stuff, I learned it from my friends and my colleagues, my collaborators that I've worked with, partners in different communities from the Pacific communities. They're the ones that taught me, because I didn't know any of this stuff, and it was like a light bulb went off in my head. I was like, oh my God, people don't know this. And when you see that rubric API, before most people assume that means Asians. They don't even think about what the PI means. But when I see that now, it's almost infuriating to me, because the communities are so different and the needs are so different. And because, again, that PI is such a small percentage of the API, their needs, their concerns, and their, you know, the problems in their communities. Like Lisa was talking about for the Marshallese, it just gets lost. So I would love for other people to share their experiences and the information they have from their own communities, because, you know, let's learn, let's teach each other and learn from each other.
Thank you, Susan. Any thoughts at this time?
Dimple, I feel like you've got something that's right on the tip of your tongue that you want to share with us.
No, nothing in particular, but I do really appreciate that all of that insight. I was not aware of just the just how much disparity there is within the subpopulation of Asian Americans, and that, you know, we really should be looking at not just cancer but all diseases, and really thinking about how we're addressing health disparities, and maybe we can find some familiarities and ways to intelligently group these subpopulations together, but this arbitrary method really doesn't help anyone.
Right.
Thank you. Thank you, Dimple. This is for me as a facilitator. If we were in person, I would break you into groups of 2 or 3 and say, chat about this. This is where it's a little bit harder working virtually. That I do want you to feel engaged, and I don't want you to feel hesitant to share your ideas and to connect with one another, because one hope is that after you all have multiple sessions together, is that you not only will be able to gain information through this process, for lack of a better term, passively, but actively. I'm hoping, we are all hoping as the organizers, that there also be connections regionally or even cross community, across the country, that you'll be able to collaborate on these efforts that we do share in common for the health and well-being of our communities. So please keep in mind that part of this too is not only the sharing of information, but it's the building of the advocacy team of champions that will take this information as and use it as a call to action in many different ways. So I do want to encourage people to share their ideas and share their thoughts, and there's no wrong or right here. It's this, you know, we're coming together as a community. And as I like to say, as I've learned from my experience working with indigenous communities, is that, you know, to have the humility that we're all teachers and we're all learners. So we all have gifts to offer one another, and we all have gifts to receive from one another, independent of our credentials or our life experiences or our years walking this planet. We're all teachers and we're all learners from all the communities that we represent.
David, can I say something? This is Lisa.
Yes, Lisa, please.
Hi, from Dallas Chinese Community Center. I just want to share some of the experience that we at the Dallas Chinese Community Center, you know, try to help with the community. And there are 2 things I want to share. You know, throughout trying to get some funding to support the medical or health related or any other issues related to Asians. Of course, our primary constituents are actually Chinese. You know, there's always a wrong or misconception about the wealth and also the family support that the Chinese folks would receive. So consequently, you know, when it comes to funding source, trying to, you know, promote this type of informational knowledge or cancer prevention or health issues, people say, well, you have Asian communities generally are pretty well-to-do, and you know, you have strong family support. But through the DCCC work, we realized there are a lot of people
they're really at the fringe of the society. They're really not the mainstream, whether it's, you know, there are plenty of Chinese like restaurant workers, so you can understand, and construction workers, and new immigrants, you know, who really don't have resource. So this misconception about Asian in general are pretty well-to-do. They don't need any funding. They don't need any help. I think it's a wrong, you know, it's a misconception that we have faced with, whether it's trying to get people to help or trying to get some funding to run programs. You run into that kind of obstacles. So that's something that, you know, throughout this years of work in the community, it becomes obvious that many people, they really don't have the resource nor the knowledge or how to if they get sick. I have been really surprised how many people are in that category. Yeah, that's
Thank you,
something I
Lisa.
want to share. Yeah.
I think it goes back to what Susan was sharing earlier about the perceptions about certain communities and the perception of the Asian American community as being this monolithic minority community about economic success and such. And people don't necessarily think of the community having needs and the disproportionate amount of people that are impacted. It's interesting, just out of, I'm not sure if any of you saw this, don't quote me on this data, but the recent unemployment data due to the pandemic and the disproportionate impact on Asian communities, the disproportionate impact on Chinese communities, and the assumption of the underreporting because of language access and residency status issues, people are reluctant to apply. And so the impact on the Chinese American community has been tremendously underreported because of service industry jobs. So it's, yeah, that point is well made, well taken.
And also about the equality, you know, this COVID has impacted all Asians. That picture Susan showed, I don't speak Spanish. I'm not, you know, I'm not, I can't remember the
I'm Hawaiian.
Yeah. Anyway, so I think a lot of Asians are lumped into one category. So when it comes to, you know, this racial tension, a lot of different Asians from different parts of Asia or the, you know, the origin, they're all impacted.
Certainly.
So there are a lot of, you know, this, you're talking about discrimination, and because of this, you know, Chinese virus that Trump has named. And then, but they really can't identify Chinese versus Vietnamese or Filipinos or Indians. And so we're all impacted together.
Yeah. Thank you, Lisa. Any other
Mr.
thoughts?
Dave? Mr. Dave?
Yes.
Hi. This is Ora Hoax. Hotep to everyone. I would just like to share from the historical perspective that Ms. Susan provided. My community, you could just put in any oppressed community's name. But the reason I joined in this training is because we had a relationship at my place of worship and the community with the local American Cancer Society. And we had fought for over 15 years to get a full-time African-American staff. And there has been such turnover because of the isms within the organization. So our last person just went to the Minnesota Health Department, and we were trained for cancer awareness. And with the absence of that relationship, they haven't reached out to our community. but we do have the African American Breast Cancer Association. There's another group now, the Breast Cancer Education group that has regular meetings. And we do an annual health fair where we are in partnership with the state of Minnesota and a local health clinic that prepares and provide mammographies within our community. And so all of these that we have come together from within our groups to know that the American Cancer Society still has not reached out to us in the absence of having a staff and haven't saw the need to replace the staff.
That's terrible.
And so it's like, okay, that's okay. And this is my term. I know that you don't want us here. You tried to eliminate us over 400 years ago. But as you had in your slide about us reaching out and having partnerships and relationship to other individuals, that's what we've done. And so that's why I'm here as a part of this training, so that I can stay engaged and have information and to be able to share information with our community so that we can have health equity. So thank you. Good seeing you, Ms. Dave.
Thank you, Reverend Doctor. I have to say in full disclosure that I had a wonderful opportunity to work with Reverend Doctor in Minnesota, where we had a multi-ethnic advocacy community come together, where we worked with African American, African immigrant, Latinx, urban American Indian, and Asian Pacific Islander and LGBTQ communities. We came together to work on advocating for health issues, specifically around tobacco as a vehicle. But I think what was very powerful was working in community, as we're giving an example of what's happening with American Cancer Society. Obviously that affects the African American community, affects all of us. And the need for us to work in partnership and solidarity, which the Reverend has always modeled for me, which I appreciate.
You know, it's disappointing to hear about the ACS that you've been trying to work with. And maybe it's just California, or maybe it's San Diego. I know that I have often been at odds with the national ACS, but the local ACS that I've worked with in several different chapters in California and in other states as well have been really great. They have done a lot of outreach. They've been the ones that have come to us asking for help, and not just help, but in partnership and providing funds and providing, jobs. And so it's really disappointing to hear that not everybody is as enlightened as they should be, but then we all know that, but it's still disappointing. It's still disappointing. But I'm delighted that you're here. I'm delighted that you're here and we're able to learn from you as much as you're learning from us. So that's great. I love it.
If there aren't any other comments at this time, what I'm going to recommend is we just take a quick stretch break, and then we'll begin to move towards our closing for the first session, because we still have some other things to cover that I think you will all find very helpful and very informative. But once again, I want to practice self-care. So if you like, you can, once again, turn your sound off, go to mute. Please don't leave the meeting, but let's just come back in like just a couple minutes. It's a quick stretch break, not a quick full 5 minute, but just a move around stretch. Okay? So okay. 2 minutes, we'll resume.